So let's start here. Continue. Hello, everyone. My name is, we have everyone on board. My name is Blessed Anuma. I am a PGY3 general surgery resident here at the Ohio State University Wexner Medical Center. I'm excited to moderate this session titled Scrubbing In, Creating a Seat at the Table, which is part of our Diversity, Equity, and Inclusion Week series. This session is hosted by the Department of Surgery, and at 1 p.m. today, Dr. Clara Park will be hosting another session that is geared towards the medical students, and that session is titled Navigating a Surgical Career. So students, be sure to tune into that session and register if you haven't already. Today, we'll be hearing from well-accomplished faculty and residents in this panel. I have the distinct pleasure of introducing our panelists today, and I'll just list out who we have here. And before we move on to ask some questions, I have Dr. Robert Merritt, I have Dr. Ben Wame, I would have Dr. Bridget Apong, Dr. Rita Shelby, Dr. Angela Paredes, and Dr. Ruth Aka. The goal of this session is to highlight our respective journeys in academic surgery, and we also hope to tackle some important questions that relate to the challenges that underrepresented minorities in medicine may experience in the workplace. We hope that by having this discussion, we can learn from everyone's experience, and hopefully this would be a great discussion panel. We also have the Q&A functionality, which would allow the audience to ask questions, and we will be looking at the chart to make sure that we answer your questions. So please type in your questions in the Q&A session. So without further ado, I'd like to start by, I will start from the top of my panel. Here I have Dr. Wame. I would ask him to just give us a brief introduction about himself and about what he does here in the medical center. So Dr. Wame. You're mute, sir.
Thank you. My name is Ben Wame. I'm a pediatric surgeon here at Ohio State and at Nationwide Children's Hospital. I'm the vice chair of global surgery at the Department of Surgery at Ohio State and the program director for pediatric surgery at Nationwide Children's Hospital.
Next on my list is, I'll just go across, Rita Shelby, you're next.
Hi, I'm Rita Shelby. I'm a fourth-year general surgery resident here at Ohio State. I am interested in academic surgery and have done quite a bit of research in my time here, and I'm working on the next steps of my career.
Thank you. The next we have Dr. Angela Paredes.
Hi, I'm Angela. I am a third-year clinical resident. I was born in Lima, Peru, and grew up in Florida and ended up in the Midwest, and I'm very happy to be here. I am interested in surgical oncology and in a career in academic surgery.
Awesome. Thank you and welcome, Angela. Next up is Dr. Robert Merritt.
Good morning. So my name is Robert Merritt. I'm the Director of Thoracic Surgery in the Department of Surgery at the Ohio State Wexner Medical Center. I've been here approximately 6.5 years. Previously, I was on faculty at Stanford Hospital and Clinics. Did cardiothoracic surgery training at Massachusetts General Hospital, and then general surgery at New York Hospital. So I've had a sort of an aspiration to be an academic surgeon, for a long time. And since my transition here to Ohio State, it's been very productive and, enjoyable time working with colleagues and, medical students and residents. So it's been very rewarding. So I look forward to participating in this panel today.
Thank you very much. Next up is Dr. Ruth Aka.
Hi, everyone. My name is Ruth Aka. I'm one of the second-year general surgery residents here at OSU Wexner Medical Center. I was born and raised in Port Arthur, Texas, and then I went to University of Texas for undergraduate and Baylor College of Medicine in Houston, Texas for medical school before moving to OSU for general surgery training. Just completed my second year here, and now I am a research resident starting out. So I'm happy to be here.
Thank you. And finally, but not least, is Dr. Bridget Apong. Dr. Apong, you're mute.
Sorry, that's the first fail of the morning. Good morning again, Bridget Opong. I'm a new breast surgeon here. I came on board here last August. Prior to that, I came from the academic setting. I came from Georgetown, then a small hospital out in Virginia. My background, just real briefly, because there's so many of us. I was born in Ghana, raised in New York. I did med school in Rochester, and actually residency in Rochester as well. Then I did my breast oncology fellowship at Sloan Kettering. I have an interest in disparities, so I'm always looking for people interested in working with us.
Perfect. Thank you so much for that introduction. So now that our audience has gotten a chance to meet everyone, I think we'll just dive right in. Just start up with a few questions, and while we wait for additional questions from the Q&A session. So my first question to the panel is, for your career, what role do you think mentorship has played in your journey thus far? And looking back in your career, do you believe that there was any, is there any importance to having a mentor of the same ethnicity or race? Did you ever have that in your career, and did that play any major role in your career? And I'll just, anyone can feel free to unmute yourself and ask, and we can go that way.
So that's a very good question. Oh, go ahead, Bridget.
Okay, no, I was going to start just saying, for me, it will be brief because I frankly didn't have any mentors in surgery, and it may be astounding for some of you guys to hear that, but I really didn't have anyone during my residency who I felt was really invested in my career, my development. I approached people, let's say if I wanted to do research, and then they were like, oh, okay, just do this and this, but I always felt like I had to do. I had to approach people, and then the response was really sort of lackluster. And I think that definitely had a negative impact. But I was persistent, right? And I didn't focus on, okay, well, let me find a person of color, because that didn't exist. I was the first Black resident. Well, I was the only, at the time I was there, I was the only Black resident. We had maybe in the middle of my 6 years there, we had a trauma surgeon who, was African-American, but, he was a new faculty also, sort of trying to go through the ropes and challenges. So he didn't serve as much of a mentor for me. I try to get external sources, especially when it came time for fellowship, because I kind of knew that, hey, I really need someone to sort of guide me through the process. And I did a program through ASCO, which is the American Society of Clinical Oncology. It's not even a surgical organization, but they had a program looking to recruit, minority physicians who want to go into oncology, and they had a subset for surgery and then for medical oncology. And it was through them that I was actually matched with Monica Morrow, who's a breast service chief at Memorial, where I interviewed at, and everything went well. So I think, you can't keep yourself in that box of, well, let me find a mentor of color, because it may not exist, or let me find a mentor in my home institution, because it also may not exist. So I think for us, we just have to be persistent and have to, really keep an open mind when it comes to mentorship, but it really is necessary. So if it's not there, don't just say, well, I don't have it, and keep it moving. You really need to try to find someone who's going to invest in your career and really have an interest in you.
Yeah, those are very good points. Unfortunately, there aren't very many underrepresented minority faculty in academic, medical centers. So there's going to be a paucity of, available mentors for, young aspiring, minority, residents, medical students who aspire to become, part of academic medicine. So with that in mind, you have to reach out for sort of national, networks of other, faculty that are minority at other institutions through organizations. Society of Black Academic Surgeons is, one possible resource where residents can reach out to these national leaders for mentorship. For me, my mentors were many. There wasn't one person. It was, my program director at my cardiothoracic residency, Dr. Mathieson, who's a very well-known, well-established thoracic surgeon. He's been very instrumental in sort of helping my career along in terms of finding my first job, finding me opportunities in the national surgical organizations like the American Board of Thoracic Surgery and the Society of Thoracic Surgeons. So through his mentorship, I've been able to, become part of these organizations at a national level. And in order for that to happen, you have to have a mentor who takes an active role in your career development, and that's important. And it's important to seek those individuals. And it may not be one person; it could be a network of people at your own institution and other institutions. So as Bridget mentioned earlier, you can't let that be the limiting factor in progressing your career. You have to really be proactive in finding these individuals in national organizations, at other institutions, because they're there. You just have to reach out to them and find them, because mentorship is critical for development and advancement in academic medicine. There's just no way around that. So I just encourage everyone to find this person or these people because they're very important for your career development.
I would echo what everybody has said. I think that mentorship is absolutely essential and it's critical. And you have a wide range of mentors. I think about sort of where I started. I didn't say this in my introduction, but before I went to medical school and started my surgical career, I was actually a neonatal ICU nurse. And I remember being a nurse and thinking, I really want to be a surgeon. I just had an attraction to it. And there was a lot of things about a career in surgery that really I thought would be fulfilling for me and bring me a lot of joy. But I was working in an area where I didn't always have a lot of interaction with surgeons. I interacted with some, but not all of the time. And, I think about the physicians I worked with then who really encouraged me to go to medical school. And they're like, why not? You can do this. Sure, it's not something that people do all the time, but why not? And, that gave me the courage to apply and to go. And then once I got to medical school, I had other mentors there and, I expressed my interest in surgery and that I wanted to be a pediatric surgeon. And, those people really carried me through. And then I got to Ohio State and I have not just one mentor, I have multiple mentors. Dr. Wame is one of them, but we have, I have other people in surgical oncology, and I am not interested in surgical oncology, but those people are also mentors to me, and they provide me with, research projects and just ways to navigate the system and to navigate my career. And so I think that as you're finding your mentors and finding people to help you along the way, you have to keep an open mind. It's good for you to have diversity because, again, even though I'm not necessarily interested in surgical oncology, those people are still just as invested in my progression and in my career and my success, and they may have a different view that you never thought about and kind of help you look outside the box and help you succeed in other ways. And I think that in other ways, while, you have diversity of mentors, I think it is also nice to have the mentors like Dr. Merritt and Dr. Wame who look like you and have had some of the experiences that you have. And so I think that that part of it is also helpful and also important, but that shouldn't be a limitation to you. Just because somebody doesn't look like you doesn't mean that they can't be a good mentor and a good sponsor for you. I think it's just an added benefit.
So I think taking on that last contribution, I think it is so important. You know, first of all, talking about sponsorship, I think you know, the reality is that you know, most of the you know, power, if you will, in American surgery today are not you know, are not held, you know, by African Americans. You know, so you know, as the old saying goes, you know, if you want to get the money, or if you know, you have to go to where, you know, you have to go to the bank, you know, right? So if you you know, if you need a sponsor that's going to make things happen for you right now, and you are going to surround yourself only by African Americans, when you ain't going to get the power, you're going to get, you know, what you are looking for. So the reality is that the power in American surgery today is held by Caucasian, you know, people. So they are the only ones that are going to extend opportunities to you. So just as a matter of being practical, you have to figure out a way to surround yourself by the people that have the power. So you can't just surround yourself by Black people. So you gotta be open to being mentored by people from, you know, all backgrounds. But I'll tell you that, you know, I'm an African immigrant, and so my story is that, you know, the first day that I arrived in this country was to do residency, and of all places, you know, I got to do my residency in Richmond, Virginia, the capital of the old Confederacy, right? So I used to walk through all those statues that are falling down in order to go to work. And, you know, when I first walked into the campus of, you know, Virginia Commonwealth University, you know, I was very scared to go to work because I had to walk through those statues, and I had to learn what each of those statues meant. And when you read the history of each of those statues, as a Black person going into work, it was pretty scary to be able to walk through those statues. I mean, you know what time you had to go to work at 4:30 in the morning. You know, walking through those statues, driving and getting waved down by police to go to work. So the first time I walked into my interview with Dr. Arnold Salzberg, the great pediatric surgeon at Virginia Commonwealth University, I was very scared, and I was visibly shaking as I walked into the room to be interviewed by the great Arnold Salzberg. And he was the reason that I went to VCU to interview for residency, because I wanted to be a pediatric surgeon. So as I opened the door, you know, he saw me, and I think he could tell that I was just scared. You know, I mean, I had just walked through all those statues. I had read all the history of this one medical school. This was the only medical school that was open during the Civil War. This was the medical school, the hospital that treated, you know, General Lee and Stonewall Jackson. I mean, I had read all the history. So he saw me and he said, "Young man, you are shaking." And you know, I thought I had my composure on, and I thought I was hiding my being scared, you know, from the great Arnold Salzberg. But he saw through all that, and he said, "You know, you are scared." And I'm like, "No, sir, I'm not." He said, "You look shaking, you're sweating." So, and I said, "No, sir." He said, "You know, sit down." And I sat down. He said, "You are scared." And then he said, "Look at the wall." So I looked behind him, and there was a picture on the wall. And the picture on the wall was of what looked like a young Black kid that looked just exactly like him, except that he was white and the boy behind him was Black, but they looked exactly the same. So I think I put, you know, one and two together, and what it turned out, you know, what I could put together was that he had a Black son. So he said, "That's my son. So don't be afraid anymore." So So I said, okay. So I think the message I thought he was giving to me was, I'm going to look out for you. You know, I understand you are being scared. I understand what you are going through. And if you were to come here to train as a resident, you know, I'm going to look out for you. I'm going to, you know, I'm prepared to mentor you. I'm prepared to look out for your career and all that and all that. And I have no doubt that he may have been responsible for my ending up to train there. And he became my mentor, but he was not Black. So to me, that was an early lesson that the race of the mentor is not as important as feeling that that individual understood where you are coming from. So the person, I think your mentor could be white or green or yellow, but I think if that individual understood that you as a Black, you know, individual have some unique issues here in America that we have all learned anew over the past several weeks that we deal with, that nobody's in denial about. And particularly that individual is not in denial about those challenges that we are all facing every day, and that person is willing to help you through, then I think that that individual is the mentor that you need, whatever their race is. So I think I was very fortunate to have learned that lesson, you know, like in my first day, you know, in this country. And I think that has allowed me to be able to explore mentorship across all kinds of, you know, race, you know, and, you know, different backgrounds. So I am very pleased that today I can count myself as somebody who has mentors from all kinds of backgrounds.
Thank you. Anyone else have anything else to add? So it seems like everyone echoes that you need not just one, but you need multiple mentors. And also the mentor doesn't necessarily have to be someone that looks like you, but someone that, you know, has the best interests, thinks about you and puts you forward to make sure that you get to where you want to be. And there is a distinction between a mentor and a sponsor, whereby your mentor is there to guide and to, you know, to sort of guide you through your career, and a sponsor is someone that opens up the door for you and puts, you know, someone that sends your CV, someone that puts you out there so that you could, you know, get promoted and people could know about your accomplishments. So those are really, and so the next question I'm going to dive in, and as we're talking, if anyone has any questions, please feel free to type them in the Q&A sessions, and we'll answer that. It could be directed to the panelists, to any particular one in the panel as well. The next question, I think this is more of a challenging one. It's on the subject of microaggression. So for people that are unaware of this term, so microaggression could be defined as intentional or unintentional verbal or physical behavior that some sort of communicates hostility or insults towards a particular person or a particular group. And I was wondering, to our panelists today, have you in your career experienced microaggression in the workplace? And if so, could you give us some examples of microaggression that you might have faced at work?
Wow, I think it's too many. And, you know, thanks for providing the definition, because frankly, so many things that you go through, I didn't have a name for it, right? These are all sort of new agey terms that now we have something to call it. But, you know, from, you know, the first incidents, frankly, was a resident when after I rounded on the patient, introduced myself as doctor, you know, I come back and the attending's like, how come you didn't see, you know, Mr. So-and-so? Like, what do you mean? Of course I saw the patient. Here's my note. Well, he's saying he didn't see a doctor, but no doctor came in here today. That's one. So, you know, things like people not even allowing you to define yourself. Like they're not even believing that you are who you say you are, right? Or you introduce yourself as doctor and then, oh, but can you hand me my bedpan? You know, I've gotten those sorts of things. You know, all these little things that, and again, I didn't call it microaggression. Now I'm saying that's probably what it was, you know, or, you know, for, especially, and for, as a Black woman, you have the gender, and then you have the race issue, right? I felt like a lot of the nurses initially were much more harder on me, especially when I was a junior trainee, you know, just certain things that they would tell the upper levels. Oh, she always came, but she was slow, or she was late, this and that. And I know, I'm like, some of these guys don't show up at all. And it's, you know, and it's okay. So those are certain things that, and you see it, you know, on all levels. I mean, like I said, I'm a relatively new faculty here. Things like my template being changed in clinic, you know, and I told them I have a 1-year-old daughter. I want to take her to daycare sometime. So can I start 8:30? You know, then I come in and my template all of a sudden is 7 o'clock. Okay, and who did that? Everybody looks around and they go, you don't know. And then, but Dr. So-and-so starts at 7. Well, I don't care. I'm not starting at 7. You know, so those are the little things that then it leads to you having a certain label if you choose to not sort of bend to the will of the other people. And these are, you know, frank, and in breast is a lot of women. So a lot of it is gender on gender politics in addition to the racial things. But there's lots of little tiny things that really, and it really piles on, you know, it piles on because we didn't have a name for it. We didn't have an outlet for it. Like, what do you do, right? Now that you know, I've been 10 years out of fellowship almost, I'm able to spot these things and I'm more comfortable addressing it because I'm in a different position of power, right? When I was a resident and, you know, if there was a complaint, you know, what power did I have to address it? You know, now it's very different. The other thing that how I've taken on sort of microaggression is now I'm able to really protect like my trainees, right? Like at Georgetown, I was on the GME committee, and what I would do is that I came up with a process to, you know, we have these 360 evaluations, and I found a way to reduce the impact of the nursing evaluations, for example, on especially the female Black residents, right? Because they're overwhelmingly negative, you know, unfairly. So it got to the point, and I was in a position where I could address it, and I was surrounded by colleagues who, after I explained to them my experience and how it goes, and looking at the pattern of the evaluations that, let's say, like the Black residents, for example, were getting from the nurses and for the non-physicians, we were able to reduce the impact on it because ultimately we saw it as an unfairness, and we saw a repeated pattern. You know, so that's sort of a really long answer, but I probably need like a day to that question. So I'll let someone else take over.
Yeah, I think, you know, the sort of the root of, you know, microaggression is, you know, it's, you know, implicit and explicit bias. I mean, that's what really, you know, drives all of these negative interactions. And it's all based on preconceived notions of, you know, people of color, African Americans, other minority groups. And it really can have a negative impact on your professional interactions, your, you know, care of your patients and your professional development and your well-being. So I think it's important to, you know, sort of, you know, attack these microaggressions head on, address them in the moment. Because if you don't, you know, they'll just accumulate, as, you know, Bridget just mentioned, because there's many, and it could, you know, happen daily or weekly. But I think it's important to, you know, identify these specific incidences or interactions and, you know, address them immediately with the perpetrator to say, look, you know, this is not appropriate. You know, this is, you know, not, you know, what I conceive as professionalism. And, you know, we need to address this here in the moment. And I think that's one way to counterbalance or counteract these microaggressions because they're just a reality of our professional lives. And we just have to recognize them as what they are and then address them and you know, remediate them immediately. Because otherwise they'll just continue to happen on a daily basis. And it affects us at all levels of, you know, training, education, being a faculty member. It just continues on and on. So I think we have to address it head on.
Can we hear from the residents? Yeah, sure.
Yes. I agree with a lot of the sentiments that have been said. It does add up. And actually recently, so I'm the chief on service right now on one of the acute care services, and I've been taking care of this lady, and every morning I go in and I say, I'm Dr. Shelby, I'm the chief resident taking care of you. And, every morning she says, oh, like, when's the doctor coming? And I say, the doctor's here, it's me. And finally yesterday she said, I know you say every morning that you're my doctor, but you just can't possibly be my doctor. And I asked her, I said, why is that? And she says, well, I don't mean to be rude, I don't mean to be disrespectful, but you're African American and you're a female. And so then we had to do a little bit of education that despite those things, or however you want to look at that I am still a physician and I still am the physician taking care of you. And she wasn't happy with the response. She's asked for somebody else, and I had to explain, well, there's nobody else. But that's not the first interaction that I've had that. I've had patients in the ER when I saw them as a consultant and, told them that they need surgery, and they asked if I would be part of their surgery. And I said yes. And, it always starts with, I don't mean to offend you, because we all know when somebody says that, it's followed by an offensive comment. And, I think in some ways, it's sad that we all agree. Like, everybody knows the minute somebody says, I don't mean to offend you, that it's an offensive comment coming. But in the same way, I think that you also have to, there are some people who you are going to be able to make an impact on and be able to change, and that there are other people that you can't. And so in these situations, I find that it's really important to take care of yourself, but to also be an example for your team. I have the opportunity and the pleasure of being the chief on service for the first time, and I really want to set an example for the juniors on service as well as for the students below me. And it's like, you don't want to, like, while it's frustrating and it can be heartbreaking, you don't want to get angry and now it becomes like an argument with the patient, because you still have to, like, preserve your professionalism as well, but while also preserving your sanity. And so I find often in these situations, I tend to pick and choose my battle. And, I will say in the most professional way that I can, I'm sorry that you feel this way. If there's somebody else I can get for you, sure. But unfortunately, in this situation, we can't. And then there's other interactions. I've been in the ICU. I remember being in the ICU where the nurses would always introduce my male colleagues as Dr. So-and-so to the patients, but then they would say, oh, and this is Rita. And to me, I picked up on it immediately, and, it was again frustrating and angering, but the time was not to correct the patient in the nurse's room. And so I wait, and we stepped aside, and I said, I've noticed a couple times you introduce Dr. So-and-so as Dr. So-and-so, but me, you introduce as Rita. And I was like, that undermines my interaction with the patient. And then they don't think that they're seeing a physician and that I just happen to be this girl who happens to be here, and they don't know who I am and what my role is. And, for that particular person, I don't think that they recognized it, but I think that was the appropriate thing, was to say, okay, this is now a repeated behavior. We need to point this out. And it was important for their education, but it was also important for my sanity. And so as you navigate these situations, I think it's important to, think about yourself, but also think about the role that you play and how, think about the example that you're setting for the people that you're educating.
And also, kind of like what you were saying, Rita, if you're ever, and any of us, and it took me a while to get to this point, but if you're ever made to be uncomfortable, by any of this, because, the microaggression is an additive strain on us, right? And if you're in a position, if a patient says something to you, don't apologize for their feelings. That's on them. And if they are uncomfortable with you, that's fine. You do not have to render them services, because there's also some medical legal implications of doing certain things. Like, you do not want that interaction. If you ever feel that way, it's okay to step away, let the attending know, let whoever know, and you know, just say, you will not engage in their care. Of course, if it's acute or emergent, that's different, but you are well within your right to do that.
And I think, to Rita's point, I think it really is taxing and frustrating to know that despite all of my education and despite all of the work that I've done, all the papers I've written, all the research projects, that people will still look at me and have some kind of assumptions because of my skin color, because of how I spell my name. And it can get frustrating. And I think what has helped me has been surrounding myself with people, with friends that see me, as more than just Angela that happens to be Peruvian and is tan, as more like Angela, who's interested in surgical oncology, who likes this kind of research, who is this way, who has this kind of personality. And I think, like, having my friends, having Rita, having Ann Blessed, some of my classmen, some of our staff that are just so supportive, that are there to listen to that frustration and tell me that it's okay, Angela. Like, it's okay that you are feeling frustrated. Your frustration is validated. I understand where you're coming from. That gives me the ability to continue to fight on another day, to be able to just brush it off and say, you know what, like, this, how this person is treating me doesn't define who I am. I still am who I am. My personality is what my personality is, and I don't have to conform to the stereotype that this person has in mind as to what their surgeon should be like. So I think it's important, especially as somebody of color, to surround yourself with a good support team, whether they are people of color, whether they're not, that truly value you for who you are and are there to help you when you have so much self-doubt, and kind of help you break that cycle.
I'm going to also agree with Angela, just because I completely agree with, I think there was something else that was said, I think by Dr. Merritt earlier today, that sometimes it depends on where the microaggressions are coming from. So as Rita pointed out, sometimes, you know, when you step up as a resident, when you step, you know, whenever you get to that level, sometimes the microaggressions comes from below, from the patients, from the nurses. But when you're still a medical student, sometimes the microaggressions are coming from above. It's coming from the faculty that you're working with. It's coming from, and like Dr. Merritt said, a lot of it has to do with implicit bias. So sometimes bias that people might not know that they might not realize that they are overtly expressing, that you're very much so feeling, but they don't feel like anything that they're saying or doing is crossing a line, or that's just how it is. That's just how I see the world. That's just my lens. And I remember as a medical student, kind of like Dr. Opong, I came from African immigrant parents who very much so are you kind of need to push forward. You need to press through anything. It really doesn't matter how people look at you, how they view you. You have to just forge a pathway for yourself and push forward. The first time I met resistance to that from, some really palpable resistance, was when I was in medical school. And although the faculty that ultimately ended up, you know, taking me under their wing and guiding me into surgery, and initially that experience was not the most pleasant, particularly because I really do believe at this point, looking back, the level of discomfort that I experienced early on, starting out with that group, had more to do with their implicit biases about what a woman could do pursuing surgery and what a minority woman could do. And had I not had the support of other classmates and friends around me who said, you know, Ruth, you know, I ended up being the only girl in my class to apply to general surgery. And this is not a class of 200 students. I was the only girl, and I was certainly the only African American to apply to general surgery. And if it had not been for classmates who basically told me, Ruth, you got this. I can tell that you were meant to do this, and you just got to press forward. And it doesn't matter if they gave you an opportunity, and you just need to take it and run with it. And you've got to just move forward and keep doing what you're doing, and just continue to show them that you are meant to be here. You earned this seat at the table. And the mentors that I had were, they were transplant surgeons. And I remember entering this research group with them, and every meeting I would go to, they would have the girls sit against the wall. And there was this young Caucasian gentleman who was in my class, who they would dote on, and they would basically tell the whole room how he was so much better than the rest of us. And he would sit at the table with the attendings, and it was things like that well, research meeting. It was these reminders that, it was subtle messages that they would send to us. They would say to us, oh, well, Dora, what do you think about this? And they would never ask any of our opinions about this, that, or the other. And it wasn't until it was probably about 3 months into working with this group, I almost decided to just leave, because I said, I just can't be treated this way. And it was a female Caucasian resident in the group who basically pulled me to the side and said, I understand your discomfort. I can see it on your face, but if you want this, you got to chase it, and you've got to prove to you have got to take the opportunity and run with it. And I am here for you, and I'm an advocate for you, and anything that you need, I am here to support you in that. And so sometimes, even if the microaggressions are coming from above, from faculty, from staff, you have to sort of look around you within your own circle, and sometimes, and recognize that even though you don't have the power to change your situation right now, you have to sort of press forward in order to sort of change your situation, in order to create that opportunity. And now where I am now, there would never be an opportunity where I will allow that type of thing to go on for a medical student who's in my presence, who's in my space. And so, back to the comments from before, it's very few and far between to find someone who looks like us, who has the same shared experiences as us. But if you don't sort of create that, if you don't press forward to create that space, that opportunity may not be created for someone who looks like you later on down the road.
That's a very good point. We have one question here from one of the audience, and I'll just read it out loud. I think it just piggybacks on what we've been talking about. Is it ever appropriate to reassign a student, colleague, or anyone else because of a patient response? And someone says, oh, now it's answered, sorry. I have never done this as a professor, but I would like to hear your thoughts. So this is coming from someone, Lynn Brophy. So is it ever appropriate to reassign a student or a colleague because of a patient response? I think we'll just ask the audience.
Boy, I think Lynn's question, it's very important, but I think you have to balance because our goal is, teachers, right? Medical students are paying for us to provide them with a certain education. If that actual encounter is going to be detrimental and not add to their education, then it's very reasonable to remove them from that situation. I frankly would remove myself. If you're telling me that, of course I'm a Black woman, so I know who Lynn is, and she wouldn't have that, but clearly if you're saying, I don't want you, I don't want your student, I will take it as, well, this is a teaching institution. You have to be clear with them that we do have trainees and residents. When you're saying you don't want this particular individual, I can't support that, and personally, I would remove that student just to protect their mental. Look at all of our experiences and all the passion just that question got for us, right? It is very detrimental. And I have that. I was, as a medical student in Rochester, assigned to my first practical experience. It was a small clinic out in rural New York, and it was full of older, all white patients and all Russian patients, right? So they're a large Eastern European population. I felt terribly uncomfortable. I mean, I was so anxious going to this place every week. And in retrospect, I should have, I was sitting there meditating, trying to get my Zen together before I walked into the space. I should have just told my advisor, listen, I can't do it. I don't want to be there. But, I'm not a millennial, and I don't have I'm not as bold as you guys are. And I love it. I love it because that cost me a lot of, just really unnecessary mental anguish. And I don't think the man would have cared if I said, I wanted to be somewhere else, right? And on that aspect, I actually requested when they asked us where we want to go. I grew up in the inner city. I wanted that experience, right? I wanted to be in a place with a diverse setting. And for me to write that specifically, and they sent me to be tortured in this rural area where I was the only Black person. Everybody looked at me when I walked in there like I was an alien. A lot of the patients refused to see me. And I did it for almost a year. Can you imagine how, in retrospect, how ridiculous that is, that I kept putting myself through that torture? It didn't help me learn, because how could I learn when you're just so stressed out? I couldn't even present cases, right, see the patient and talk to the attending, because I was so nervous all the time. And he, he's like, well, you need help with presenting. And I couldn't articulate that. My problem is that the patients don't want to see me. I'm not comfortable. And I could have saved myself a lot of mental anguish if I would have just spoken up and say, hey, I don't want to do that. So I'm very keen on not putting any trainee that I'm working with in that particular situation. And I'm not putting myself in that situation. Like the wonderful thing about the internet is that they see who you are before they come into your practice. If you don't want a Black doctor, you need to roll on elsewhere. And I'm totally fine with that.
Yeah, no, I agree with Bridget completely. That's not a good learning environment for a medical student to be in a hostile situation with a patient who clearly is overtly biased against that person because of their race. So I think taking the medical student out of that situation is appropriate. And also, quite frankly, if patients don't feel comfortable with their provider, then there's other providers that we can link that patient up with who they may have a preference for, and that's perfectly fine. The patient-physician relationship really, is built on, mutual trust and respect. And if that isn't there, then that relationship is going to fail. So it makes perfect sense to, find that, patient, another medical student, or another provider. So I think that's perfectly appropriate.
I think the other thing that's important too is that, while this is a learning institution and, I think the default is you want to keep the student or the resident there and engaged. I think that only works if there's support on the other side. For instance, Dr. Opong, you described, the situation where your attending is like, this patient is saying that they haven't seen a doctor. And, if your attending doesn't understand the nuances of what's going on and what the relationship is, then it makes it even more difficult. So I need a champion or somebody on my side to say, I recognize that you are seeing this patient and that you're taking care of this patient. It's just that this patient in particular is not willing to accept that you are the physician that's seeing them every morning, and that I recognize that you're not neglecting the patient. And I've had some attendings who do that. We go into when we round together and the patient's like, I haven't seen a doctor. They're like, what are you talking about? Dr. Shelby was here earlier this morning. Do you not recognize her? And they're like, oh, she's the doctor? And they're like, yes, she's the doctor. And so you need the other side of it for it to be a successful relationship. But if you don't have that, then yes, I think it's best to take the student or the resident out of that situation.
Right. I hope that it will never come to actually ever taking a student or resident out of that situation. And I have promised myself that I would never participate in taking a student or resident out of that situation. And I will work very hard to never allow it to get to that point. And I think that what Dr. Shelby said earlier on is really important, and that is that I often see this as a moment for education because a lot of time there's a lot of ignorance that fits into this, into this situation. So my first reaction is that this is an opportunity for education. And that's, at least in my experience, almost always resolves the issue and prevents the need for any of these drastic, steps. For example, I was in clinic just, last week, and the medical student that I had, this was in fact, the student's very first clinic for the year. This was, the student's very first, clinic in medical school. So, she was very nervous. And what I said to her is, number one, you have every right to be here. You are qualified to be here. You are ready. You are competent. You should not feel sorry for being here. And the first thing we're going to do is that we are actually going to tell the patient that this is your very first clinic. And you will be surprised by the shower of kindness that the patient is going to show you. So don't feel sorry. Don't be afraid. I am going to support you. And I promise you the patient is going to support you and love you back. So the first thing we're going to do is that we're going to introduce you for exactly what you are. I'm not going to say you're a student doctor. I don't like that word, student doctor. I'm going to say you are a medical student, because that's what you are. And that's exactly what we did. Okay, so I say, just go in there and say, I'm a medical student. I am here to interview you about your child, and I'm going to gather information. And then I'm going to present you a case to Dr. Nwome, and then he's going to come in, and then we're going to continue from there. And every single patient that she approached that way was very cooperative. There was absolutely no incident. This has been my experience. And whenever we have had a situation where a patient has said, I don't want a medical student involved, or I don't have a student involved, my approach has always been to go back to that parent and explain the role of the medical student, or explain the role of the resident, and explain that, the way that our system is set up, this is a teaching hospital, and this is actually why we have medical students. This is why we have residents, and then ask for their cooperation. And if you invest the time to explain this in a respectful way, my experience has always been that they relent. I have never had a single situation where they did not relent. Now, if I were to ever face a situation where they refuse to relent, if that were ever to happen, that has never happened to me. But if that were ever to happen, my intention is to offer them a different physician. My intention would be to call my, the people, my bosses, and explain to them that I'm in a situation where I truly, don't feel that I can offer my services to this individual, because I feel committed to providing excellent care in a teaching environment. And I feel like I'm being separated from one, and the other. Maybe there are some of my colleagues that are willing to provide the care, but without the teaching. And if that is the case, then that patient is entitled to have that individual. But I have never been faced with that situation. So, but if the hospital that I work for is willing to provide medical care to patients and exempt that patient from, the teaching that I believe comes with it, I believe that will be, that will create an unequal level of care where some patients are being subject to teaching and some other patients are not being subject to teaching. I don't believe that that's what my hospital stands for. So I have never, in 17 years, I have never faced that situation. But I believe that you should take that as a moment for education, and in my experience, 100% of patients respond to that.
Sorry, I realized I was mute. There's a question on the chat, and I'll read it out loud. So M3 about to enter clinicals. I would like to impress in rotations, but clearly don't want to stick out too much. Though being Black always sticks out. I will prepare knowledge-wise because at the end of the day, this is most important, for pimping, that's asking questions. But my concern or question is, did you ever modify your look, hairstyle, style of appearance more conservative to fit in or to be more accepted by the attendants? What is the best approach here? At the end of the day, we need to match, just hoping things such as my look don't deter programs from preferring me. Wow. Okay. So any of our panelists wants to answer that question?
Oh, that's a really great question. I feel like I'm probably talking way too much, but it's just, these are such great questions. And it just calls into mind all the stuff that I had to go through. This is the same conversation I had. So I've had natural hair since I was 17. And when I graduated from college, my mom said to me, listen, you want to go to medical school, you need to go perm your hair. So to those of you who don't know, it's like you have to straighten your hair. And I was like, I'm not doing that. I've been done with that for years. And my advisor said, listen, people are not going to take you if you don't straighten your hair. They're going to look at you differently. Natural hair is not as neat, all of these things. And it's unfortunate, but it is a reality. So I did it. I straightened my hair for the interviews. And then once I got in, I went back to my natural hair. My parents are African immigrants, just like kind of Ruth was saying about her parents, is like, listen, do what you got to do to get what you want. And once you get there, then you can do whatever you want. So my hair, I have braids. I still have natural hair. I do whatever I want. At the end of the day, I think if it's neat, it's fine, right? If you're going to have a fro, don't let it be all over the place. Tone it down, keep it neat. And like all hairstyles, and I have white friends who go through this too, right? Like I had a friend of mine who is a white guy with a ponytail. They told him, you need to go cut your ponytail, right? So there is a reality. Medicine in general is very conservative. So there is a certain look. And that goes to, I had also a student who had tattoos, and we told him, you wear a suit and all that's covered, but he actually had it on his hands and stuff like that. Those are conversations that, listen, medicine is very conservative. Despite what we say, everybody wants to sound like we're open-minded in certain things, but the reality is that, we're part of a really small group of super conservative individuals that's going to impact your opportunity. How you look, when I was at Georgetown, they brought in my director of the breast program. She looked like the rest of them, blonde, pearls, Chanel suit, that look, and I'm never going to get there. I'm never going to have that look. So it's not even something for me to attempt to emulate, right? But those are things, optics do matter. So ultimately, within reason, keep your hair neat. I had dreads, actually. I had dreadlocks when I was a resident. So like I said, I've had it all. And again, frankly, I think most people don't even know the difference between braids and dreads and all of that stuff. The reality is you keep it neat. I always kept my hair sort of back. And for men, you have a beard or whatever, keep it nicely trimmed. And I think that goes whether black, white, or anything else. It's just realize that especially surgery is very conservative. There's so it's not going to work. But at the end of the day, if you want natural hair, have your natural hair. There's plenty of products now. There's plenty of styles that you can have that can still look very professional and you'll be fine. But I went through this, like I said, this was almost 15, 16 years ago. And then it was very different. A lot of women didn't have natural hair and everybody told me I was nuts. And like I said, I did fall for it and was pressured into straightening my hair temporarily. But I think now it's people are a lot more open-minded, at least when it comes to that.
I think that's a important question, and Dr. Opong hit on a lot of really important points. I personally never felt like I had to change my attire or how I looked. I think that the key point is to just be professional, no matter what you choose to wear. I think, for me personally, once you get to know me, I'm a pretty strong personality, and I like to stand up for what is right, whether it's beneficial to me or beneficial to other people. And I think one of the things that I've noticed is even when I'm being as professional as I can be, it's very easy for people to interpret that we're angry. And, you know, there comes the term of the angry Black woman. And so I found myself in the beginning that I would sort of temper what I said. I didn't always say what I thought needed to be said, in fear of being accused of being a bully or, you know, being mean to somebody or being mean to the nurses. So much so that I felt like oftentimes in the beginning, you know, things that were really important for patient care, like I wasn't saying because I didn't want to be interpreted as being mean or angry all the time. And finally, I realized that, you know, I came here for a job and to do a good job, which is to take really good care of patients. And so I still maintain my professionalism, but sometimes, you know, you have to be a little forward and a little, you know, upfront, but I'm always nice about it. But I don't necessarily hold back. And so if there are things that you're concerned about, I encourage you to find a way to say those things, but still maintain your professionalism. And I think, I don't know, my co-residents on here can sort of tell me, but I think I found the balance. And so, like, you know, that's really what it is all of this is a work in progress. They're learning, we're learning. As long as we keep an open mind and try to find the balance, I think that that's where we're all going to like really make the biggest difference, you know? So yes, there are some things that you have to change, but you shouldn't have to change your entire person and who you are, you know, in order to be a successful and productive physician. Like, that's not what this job requires.
I agree with Rita's sentiments. I think that you don't have to change who you are as a person. I don't think that you have to completely turn over who you are, but I will say that you would be dreaming if you thought that, you know, appearances don't matter, especially in medicine, because it is still a very conservative field. And I personally, from experience interviewing for residency, had multiple interactions, had people comment on my appearance. And I mean, growing up in Texas and in a very from a very conservative type of, in a very conservative environment, it was very palpable that you were perceived a different way based on what you came to work looking like. And if you came to work with, you know, with straight, more conservative hair or something like that, you were just were received in a different light in some situations. And so I wouldn't say that, I don't think that you have to, you know, completely turn over your own personal style or anything like that, but you do have to be mindful that, you know, a lot of the people who still are in positions of authority, who make the decision on whether or not to hire you versus whether or not to sort of bring you into those circles, a lot of those people are still very conservative individuals. And, you know, if you want to sort of not eliminate some of those opportunities for yourself, you do have to sort of respect the fact that you kind of have to take a little bit more of a conservative approach when it comes to appearances and things like that.
Yeah, I agree with all the points that have just been made by all the panelists. You know, surgery is very conservative. When I was a resident at Memorial Sloan Kettering, you know, I had to wear a shirt and a tie and a clean white coat. Could not wear surgical scrubs on the floors. It was very conservative. So that, you know, is kind of the, you know, what I'm used to and accustomed to because of that, you know, rigid, you know, sort of dress code and expectation. But I think there's a balance. You want to maintain part of who you are as a person. You don't want to become something else or someone else just to blend in or assimilate. I think that's kind of too drastic. But I think you want to remain professional and present, your best, sort of light forward, to everyone. So I think there's a balance between maintaining who you are and sort of, having a professional, appearance and look, because I think that's important as well.
All right, I will dive into our next question, and I think this is a very important question, and probably my favorite question, if I'm being a little bit biased here. This is a question about increasing and retaining underrepresented minority faculty and residents in surgery. As a couple of the panelists have alluded, it's good to have diversity as part of your mentor team. Because you get, again, a broad spectrum of idea of different people. But also there is research that has shown that, that a diverse workforce and a workplace actually promotes productivity. So it's obvious that diversity is a valued asset to a program and to surgery in general. What are some initiatives or what are some solutions that you think the program or surgery in general can, that we can actually do or implement to sort of increase and retain underrepresented minorities and faculties in surgery?
So I'm blessed. I'll get started. So I think, we have to start early in, education experiences. We have to, reach out to, kids that are in, high school, undergraduates, to introduce them to the field of medicine, that, this is a potential career pathway for them, because those are the formative years. Those are kind of the times when people kind of decide, what they're going to do with their lives. And I think, the earlier we intervene and expose them to, people that are in the profession that are similar to them, we can, tell them the benefits of the profession and, the challenges and what they need to prepare themselves, for medical school, for residency, and for becoming a faculty. I think the earlier we start in the process, the more successful we'll be. It's like, creating a pipeline. And the earlier you start, I think the more successful the initiative will be.
So one of the things I'm most excited about is what our Department of Surgery, under the leadership of our chair, Dr. Pollack, is doing, as well as the initiative to do exactly what Dr. Merritt just said, which is to try to create a pipeline, a program. So if you don't mind, I'll just tell a story of one of the most impactful experiences that I had that occurred in the very first few days after I arrived in this country. And that again was, in the place where I trained, in Virginia. So the first few days, I was riding in an elevator and I met two Black kids. They were about the age of 8 and 9. So the two of them approached me. I was wearing scrubs, green scrubs and a white coat. And the two of them saw me and they were debating among themselves whether to talk to me. And so they were muttering among themselves. And one of them was like, yeah, you talk to him. The other one, no, you talk to him, you talk to him. And eventually one of them summoned up the courage to come to me. And then he said, excuse me, sir. And I said, yes. Are you a doctor? And I said, yes, sir. I mean, like a real doctor? And I said, yes, sir. Like real doctor? And I said, yes, sir. And then he said, shoot. And then they ran away. They just ran away. And I was like, stop. I wanted to talk to them. And then they ran away. Never saw them again. And I was so puzzled. I had been in this country only 2 days when this happened. And I thought about it for so long. It took me like several weeks to process what happened. And eventually when I understood what happened, I realized that these 8, 9-year-olds had seen me, somebody that looked like them, And they just did not believe that a young Black man that looked like them could be a doctor in these United States of America. You know, and I was just thinking, when I was their age, in some remote village in Africa, I knew that I wanted to be a doctor, and I believed it. And I had a 5th grade teacher somewhere in my life that I told I wanted to be a doctor, and he helped to motivate me on a path that eventually led to me not only becoming a doctor, but arriving here in the United States to pursue my dream of being a surgeon. So the whole idea of creating a pipeline where young Black kids will believe that they could become physicians is so central to our creating this dream of people becoming academic surgeons. And I don't think you can just take it off the shelf somewhere in the middle, but I think you really, really have to start at the bottom. So I think that what our department is doing and recognizing that we have to really, really start early is so important.
I think the other theme that's important and something that has really come to the front lines lately is the idea of allyship. I think that, you know, the other side, so, you know, our program directors and our departments, the chairs have to recognize that it's a different experience for underrepresented minors coming into medicine, coming into surgery, you know, progressing from residency to professorship, and that we have different challenges, and, you know, and those are part of our experience and our progression as well. And to sort of, you know, they're never going to understand what it's like to be a Black surgery resident, you know, if you're not a Black surgery resident, but to understand that there's different challenges and different things that contribute to our experience and how we may progress differently from the program, and to sort of support us in that difference, and help us, you know, overcome some of the challenges that we may have that may be different from the mainstream. And, you know, understand that, you know, maybe sometimes I'm having, you know, a difficult time because of these things. Because I think that sometimes things that force people away or run people away is the responses that are like, you know, you have an experience with a colleague or a patient, and, you know, we get the microaggressions, we talked about it ad nauseum, and you're like, you know, this person said this to me, or I felt this, and, you know, the response is, well, I don't think that they really said that because you're Black. And so, like, those kind of things and comments, you know, things to like really just be aware of, because I think those are experiences that I may not necessarily tell you, but I'm going to tell my friends and tell other people, and that may keep students and others from wanting to look into our program because they're afraid that they would have bad experiences. And so it's just that idea of allyship, and like, you know, I don't necessarily understand where you're at, but I'm hearing you and I'm here for you.
And I think it's also important to, if possible, to be training at a program where you can find people that resemble you. Because sometimes you look out into the crowd, and it's happened, I've gone to conferences and I look out and I took like a moment and I was like, there is absolutely no other Hispanic in this room, let alone a female Hispanic. Like, do I really belong here? Like, is this supposed to be where I am at? And I remember talking about this with Dr. Opong at a meeting that we had about a recruitment thing. And she was like, Angela, that's a self-imposed barrier that you're putting on yourself. No one at the conference is saying that you don't belong here. No one is saying that you shouldn't be there. But you, for whatever reason, feel like you don't belong. But I'm sitting there next to Dr. Pollack. I'm presenting research with Dr. Pollack. I have this great opportunity to do so, but somehow I feel like, you know, because no one here in this room looks like I do, like, am I supposed to be here? Am I one day going to be able to be a member of the American Surgical Association? Could I one day be a chair? You know, and so surrounding yourself, finding people that look like you, that, you know, like if she did it, if Dr. Opong made it and is is now a great surgeon. Like, could I be that too? And so I think it's finding those people. They don't necessarily have to be within your own program. It'd be great if they were, because then they're easily accessible. But there are people out there that have fought through this really mental battle to get to feeling like they belong, that they're very much appropriate to be a chair at a department of surgery across the country, that they deserve a seat at the table. They worked hard. And I think that's what drives me too, so that one day I could be the example for a younger generation that is to come, that says, you know what, like if Angela could do it, well, by golly, like I should be able to do it too. And so I think that's what gets me through those moments when I'm like, you know what, do I really belong here? Like, should I really be presenting? Like, did my paper really, should it really have been published? Like, am I appropriate to publish in these journals? But when I really am, like, I worked hard, I did the work, I did it. Like, why shouldn't I be enjoying that experience? But I think sometimes we self-impose that on ourselves. And I think that's also something that I'm trying to work on.
Yeah, no, that's the classic imposter syndrome, where people of color, minorities feel inadequate or that they don't belong at the table. But you know, if you've put in the work, you've demonstrated competency, you know, you've published the papers, did the presentations, you know, developed some new surgical technique. I mean, you're as, you know, you should be there as much as the next person. And I think, you know, overcoming that barrier is very important, because it's all of the, you know, the additive effect of the microaggressions. You know, you feel like you don't belong and you're inadequate, but you know, that's our challenge. We have to overcome that. But if you're there for a reason and you've earned a spot there. So that's something that we all need to keep in mind and, you know, convey that to the younger generation. And that's very important. So thanks for bringing that up.
That's why our session is titled Scrubbing In, Creating a Seat at the Table. And we hope that we can inspire people and let you know that you actually belong here. You know, you're part of this group, and as you can hear from our shared collective experiences, we are here, we're thriving, and so can you. You know, with the opportunity out there. We only have like 12 minutes left, so I think I have time for one more question. And this could be personal or any way you want to look at it, but my final question is, what career advice would you give to your younger self? So if you're looking back now, how far along you are in your career, what advice would you give to yourself at this present age? 2020, COVID era, post-apocalyptic era, whatever you want to call it.
Wow. I think I would speak up more. Like a lot of the, you know, little things like the microaggressions, and I didn't know what it was, right? You always think, and sometimes you don't know, am I overthinking it? Oh, you have that certain level of self-doubt. But I think I would have been better at verbalizing, you know, and trying to explain to people what was happening and somehow try to correct the situation. You know, I just let stuff go. Then after a while, you know, we talked about the perceived stereotype of us being angry, especially Black women. But a lot of that is things get pent up sometimes. It gets pent up and you don't let things sort of, you know, it simmers, and then maybe you may explode at a situation where it wasn't really deserving of that response, but nobody really knows the backstory, you know. So I think that could have been, and I was actually the opposite. I was very quiet, very withdrawn, and even that in itself had its negatives. People are like, well, she's disinterested, or, you know, she's not a go-getter, you know, all of these little words. And it's just because you feel isolated, so you just sort of keep to yourself, and that limits your opportunities. The other part of that is, you know, I would have been more, you know, just more interactive with the faculty, you know, because again, I was the only person of color. I think along with that is sort of, you know, you're so painfully aware of being different, right? A lot of it is you perceive that, but other people make you feel that way as well. Over time, you just, you know, you're not present. And we're talking about a seat at the table. You have to get there, right? And I, in many situations, just wouldn't go. I wouldn't go to events. I was just like, I don't want to deal with them. I have to deal with these people all day. I'm going to go home and hang out with my friends, which was important. You get support from my crew, but then, you have to go to the department functions. I didn't go to meet certain people, and there could have been certain faculty who could have been allies or could have been better allies if I had given them the opportunity. So I think I did miss out on certain interactions, missed out on meeting certain people just because of my sort of self-limitation or my perception of how I would be accepted.
Yeah, I think that's an excellent point. I think often we tend to isolate ourselves at the national meetings, but that's an opportunity to network and then talk to other colleagues at other institutions to, form collaborations and, research projects, clinical trials. I mean, all these opportunities come from networking. And, we tend to not do that, because of lack of affinity for other people at the meetings, but I think we have to overcome that and do more networking and reach out. And the other thing that I think is important for me as a Black faculty is to be a support for the residents, for the medical students that are at this institution. So I just wanted to make myself available to all of you all. If you ever need to talk to me or reach out to me, please do that. We often get caught up in our own careers and, taking care of patients, trying to, do research and all these other things. And we often, forget that that's an important part of our responsibility and our mission is to, help the next generation of residents and medical students. So I'm just putting that out there. So if you guys ever need to reach out, please do so.
Some of the advice that I would give is, if I had to give some advice to my younger self, is don't be afraid to make your presence known, and to surround yourself with people who support you and push you to be your best self. There's definitely strength in numbers. I remember when I was a medical student, one of the things that I thought was most intimidating was being a woman, and no less a Black woman, trying to sort of network with or to interact with these Caucasian male white attendings, and to sort of try to garner their support or feel like I'm trying to fit in, so that I can have the same level of support in order to pursue my career in surgery as well, the same way that all of the other guys who were trying to apply to general surgery were. And I remember it being me especially feeling out of place, because I felt like the connection was almost so much more natural for the guys to sort of pick up sports conversation with these attendings, or that it was, or that I couldn't just step up and interact with the attendees the same way that all of these white male medical students were interacting with the attendings. But I think that sometimes part of that, like someone said earlier before, some of that is part of is you sort of projecting those things onto yourself, that you don't belong here, and then sort of re-perpetuating those and recreating those situations that sort of leave you an outlier. But sometimes if you know that this is where, once you have an opportunity to step into the door, once you get your opportunity at the table, you need to take it and you need to run with it, and bring others along with you. And one of the ways that I sort of was able to break that barrier was I brought along a friend who was, when I started going to these research meetings with these transplant surgeon attendings who were all white males, who obviously had a much more natural affinity towards, white male students, because they just started naturally talking about locker room talk and different things like that. I started bringing along an Indian girlfriend who was also interested in a surgical field, not necessarily general surgery, but that sort of broke the barrier that, there's more than one of us here. You're not going to just put me to the side and ignore me. And so there's strength in numbers. Find those people who genuinely care about you and make you better. Sometimes those individuals come in unexpected packages. And once you find an opportunity, take it and run with it.
Point. Very good point. Anyone else?
Yeah. So one of the things that one of the greatest mentors I've had up to date, Dr. Besner, who's also a pediatric surgeon over at Nationwide, is work hard despite your difficulties and despite all the other negative things that are going on. Work hard despite your challenges, because when you work as hard as you possibly can, there comes to a point where people can't deny your greatness. And so every day I wake up trying to work as hard as I possibly can, despite all of the things that's going on. It doesn't mean ignore all of the things that are going on, but use those things as your strength to drive you to work even harder, so that they can be like, I didn't like Rita's hair today, but by golly, she works really, really hard, because that you can't deny.
Great point, Rita. Great point.
I think maybe mine is just the opposite of Rita's. Not that there is something wrong with that, but I think, as somebody who has, maybe sort of at the end, sort of approaching the end of the, being the end product of that working hard, from being the child of, refugees who survived the Civil War, and then having to work my way up to being an immigrant here in the United States, and being, unfortunately, when you are, a Black professional, even here in the United States, even in the year 2020, you are still going to be the first of many things. And to do that, you have to work extremely hard. And you do get burnt out. You do get burnt out. We all kind of used to, working twice as hard, in order to achieve anything. And, at the end of the day, you just get exhausted. You just get to the point of just being exhausted. And you miss out on a lot on life, and it takes its toll. And it leaves just a lot of bodies along the way. And some of that, are friends and family and yourself. And sometimes you just look back and you wonder, is it worth it? There are some moments where you feel that maybe it wasn't. And that, maybe there are some of it that you wish you hadn't done. That maybe you could have done things a little bit differently, even though you feel that also at the same time that all of it was necessary. Who else could have done it? Who else could have opened these doors for yourself or other people? So there's a lot of regrets. You sort of feel like you're a sacrificial lamb for yourself, or for your family, for your people. So I don't know what the answer is. Some of it is sort of a historical, not that you're Martin Luther King or, anything like that, but you're sort of, part of, you've played a certain role for yourself and for your family and for the cause, if you will. But you've paid a price as well. And maybe there's a way that you could have done things differently. You certainly see pieces of things that you could have done differently, but the outcome could have also have been different. And sometimes you just wish that you were just normal like other people, right? You didn't have to take all these extreme measures, work twice as hard, come in, stay late, in order to perfect your gel when you were in the lab, so that, you don't have to get the criticism in the morning. So I think there are lots of things I wish I could have done differently, but I also wish I could have just been normal like every other person.
Very good. Last thing, Angela, do you have anything to add? If not.
I think to Dr. Nawame's point, I think it's just not losing your sense of self. like whatever is important to you at that moment in time was important to you for whatever reason. What was important to me as an 11-year-old is very different than what's important to me now as a, however old I am, 30-something-year-old. I can't remember. But I think knowing that every decision that I am making, it's a conscious decision, that I am not being forced, that the decision to take on this opportunity at this moment in time, I believe to be the best decision for me based on the information in front. And yes, I will know 10 years from now whether that was actually the best decision. But at this moment in time, based on the information I have at hand, that this is what's best for me, that I truly believe this is what's best for me as Angela. And not losing that, not losing my ability or my willingness to take some time for myself, that it's okay that I take 30 minutes, an hour to go work out, that the surgery's still gonna happen, the day's still gonna go on. Like, it's okay that I take care of myself. And I think sometimes I've forgotten about that and I prioritize everybody else over myself. But it's okay that I take 30 minutes, 45 minutes and do something that's important to me, whether it's talk to my sisters, FaceTime with them, go outside for a walk, go out to dinner, whatever it is, that my mental health, my emotional health is also really important.
So all great points. Unfortunately, we are out of time. I'd like to take a moment to thank our panelists today. We appreciate your time and your effort. And as everyone has heard, this has been a great discussion. Hopefully, we've been able to inspire our audience, and hopefully you've learned from our collective experiences today. Don't forget, at 1 p.m., Dr. Clara Park will be hosting another session titled Navigating a Surgical Career. So please tune in at that time, and that's geared towards the medical students. So thank you everyone for your time. Thank you panelists, and thank you for the participants for being here today. We value your time as well. So thank you.
Thanks. Take care, everyone.
Bye.